your host for today. The main goal of this event is to enhance the knowledge of basics in coagulation through interactive hands-on training. This is mainly intended for postgraduate students in transfusion medicine and pathology. The program would be from today, the 6th to 10th January 2024. We have a power-packed few days planned for you, where you will be enjoying the expertise of key opinion leaders on coagulation. First, for the welcome address, I'd like to invite none other than Dr. Sushila Jacob Inna ma'am, the doyen herself. CASCADE is her brainchild, which she started 13 years back. She now serves as the Chief of Laboratory Services and as a Professor Emeritus in the Department of Immunohematology and Transfusion Medicine, Jubilee Mission Medical College and Research Institute. She earned her MBBS degree along with postgraduate qualifications, DCP and MD Pathology from the esteemed Government Medical College, Thiruvananthapuram, Kerala. Ma'am has made significant contributions through the numerous scientific publications in medical journals of both national and international repute. She is also a co-author of a chapter in the Confidential Review of Maternal Deaths, published in 2021 by the Kerala Federation of Obstetrics and Gynecology. Dr. Sushila ma'am has also served in a key role as the Joint Director of Blood Safety at the Kerala State AIDS Control Organization. With such an impressive academic background, extensive research contributions, and invaluable experience in healthcare administration, she is undoubtedly a beacon of knowledge and expertise in our community. So without further ado, let's warmly welcome Dr. Sushila ma'am to deliver the inaugural address. Over to you, ma'am.
Thank you, Pooja. And a very warm welcome to one and all. At the outset, at the beginning, when it's my duty to welcome each one of you. Like, even though I don't see many of you, I would like to welcome all the participants of this Cascade 2023. A little introduction on what made me start this workshop. Basically, I'm a pathologist with very little. I had very little knowledge on coagulation because coagulation or hemostasis testing was not considered very important in those days, long back. So in 2009, I attended a hands-on workshop in CMC Vellore. And the interest, how I got interested was the way in which they conducted the workshop, and how I thought it is really important for us because we have a lot of patients with a little bleeding problems, and we don't diagnose what it is, we just treat. Without knowing what's the cause of the bleeding problem, we just treat. So I thought that pathologists and transfusion medicine, at least PGs, should understand what is the problem, and they should start learning on the testing of coagulation. That's how in 2011, I thought that we should conduct a workshop, and which was conducted in a very small way with only PGs in pathology. And I think we had PG in Trivandrum. So PG transfusion medicine PGs from Trivandrum, and the pathology PGs from all over the state. So this was started like that. And after we started transfusion medicine MD, this program got more impact in the field of transfusion medicine, and we started getting more PGs from the state. And later it became, and COVID was one important thing that brought more impact to this workshop because we started doing it hybrid also. And so let me come to the point. I would like to thank each one of you who have registered and who have shown the interest to participate in this academic program, whether it is by the hands-on or the hybrid mode. And those of you who have joined for the hands-on workshop, I hope the 3 days that you're going to spend in Jubilee, you will make maximum use of the 3 days that you're going to be here with us. And I ensure you that you will be given, you will enjoy your stay here. And I hope you will enjoy being with us for 3 days, and you will go back with memories of Jubilee Mission Medical College. Thank you very much.
Thank you, ma'am. It is my great pleasure to introduce our first speaker for today, Dr. Biju Bahulayan. Ma'am will be speaking on the topic Physiology of Coagulation. Before that, a brief introduction. She is the professor and head of the Department of Physiology, Jubilee Mission Medical College and Research Institute, Thrissur, Kerala. Our speaker is not just a teacher, but a conscientious and flexible educator, adept at using social skills and empathy to manage student behavior. Known for her ability to harness feedback from students, she crafts compelling lesson plans tailored to the strengths and weaknesses of each individual learner. Dr. Biju ma'am did her MBBS from Government Medical College Thrissur during the years 1991 to 96. She did her post-graduation in MD Physiology from Government Medical College Trivandrum from 2002 to 2005 and further pursued DNB Physiology in 2006. With an impressive 21 years of teaching experience, spanning both undergraduates and postgraduates, she has left an indelible mark on the academic landscape. Her commitment to education is reflected not only in the classroom, but also through their guidance as a research guide for UG, PG, and PhD students. Beyond teaching, ma'am is a prolific researcher boasting more than 40 publications in national and international journals. She is also a research guide and a vital member of the Institutional Ethics Committee, serving as the member secretary. Adding to her multifaceted role, Dr. Biju ma'am is a valued faculty member in the Board of Studies at UG Kuhas, Kerala. I welcome to you the stage, ma'am.
Very good morning to all. At the outset, I would like to thank the organizers of this cascade for considering me again to present my topic, Physiology of Coagulation. So moving on to my topic, Physiology of Coagulation. So the word hemostasis means the cessation of bleeding from a blood vessel. So when we consider about the cessation of bleeding from a blood vessel, as you can see over here, any small injury to the blood vessel, we have a full set of events taking place with the different cells coming and closing off and sealing off that gap. Now, what you see over here is a fast forward form of hemostasis taking place. Now we are going to decode this and discuss this turn by turn. So for hemostasis, what we have said earlier is from where the bleeding starts to bleeding stops. And the three main pillars which helps in the stoppage of bleeding. The first phase is the vascular phase, followed by the platelet plug formation and the stable fibrin clot formation. So we'll start with the vascular phase. What happens immediately as soon as the bleeding starts? What happens to the vessels? In the vascular phase, as you can see over here, as soon as there's a break and when the bleeding starts, the vessels go into vasospasm. Now, this vasospasm is sufficient to stop bleeding in the case of small blood vessels. But in the case of medium-sized blood vessels, this would not be enough. So just decoding about the mechanism of vasospasm, what exactly is the physiology behind this vasospasm? The mechanisms involved is the local neural reflexes are being activated in the blood vessels, which results in the smooth muscles of the blood vessels to contract. We also have the damaged endothelial cells releasing endothelin-1, the platelets which release serotonin and histamine, and we also have the activated platelets releasing thromboxane A2. So all these components together act to cause the first phase, that is the vascular spasm phase of hemostasis. Now, like I said earlier, for small blood vessels, this is sufficient to stop bleeding. But for medium-sized blood vessels or for large blood vessels, they can only decrease the amount of blood loss, but it cannot stop the bleeding. So this triggers on to move to the next phase, that is the primary hemostasis, the formation of platelet plug. Now, as you can see over here, we have an injury in the blood vessel, and you can see the platelets coming and attaching and sealing off the injured site. Now, the sealing of the injured site involves certain properties of platelets. So we again decode this phenomena turn by turn. We start with the properties of the platelets. The first property of the platelet is platelet adhesion. As you can see over here, the platelets come and attach to the linings of the injured site. Now, what is the basic physiology behind this? How does this come and attach? As you can see over here, whenever there's a damage to the endothelial cells, the underlying collagen is being exposed. So the platelets come and bind to the underlying collagen directly or with the help of von Willebrand factor. It binds directly with the help of receptors which is present on the surface of the platelets, that is the glycoprotein 1A, 2A receptor, or with the help of von Willebrand factor through GP 1B, 9 and 5 receptors. So this ensures the adhesion of platelets. So platelets come and adhere to the site of injury. Now moving on to the next property of platelets is activation. Following adhesion, the platelets gets activated, and what you see over here is a change in the structure of the platelets. It puts out the spiny processes and it starts releasing the contents of its granules. Now, as you can see over here, the contents of the granules of the platelets have alpha and the dense granules, and these are the contents of the alpha granules. We have factor 5, factor 8, fibrinogen, platelet factor 4. We also have the dense granules, that is ADP, ATP, calcium. And again, we had discussed this in the vascular phase. We have the histamine and serotonin, which is being released. Now, what happens over here is the contents of the granules that is released, mainly the ADP, binds with receptors which are present on the surface of the platelets itself. As we move on to the next stage, what we see over here is there's adhesion followed by activation, and what you see over here is the exocytosis or the contents of the granules that is being released. Now, the contents of the dense granules, it's mainly ATP, which binds with G protein linked receptors which are present on the surface of the platelets, leading on to activation of PLA2. And now when PLA2 is activated, what happens is it changes the surface of the membrane, inserting new receptors on the surface. That is glycoprotein 2B, 3A receptor on the surface of the platelets. Now this receptor binds to fibrinogen, which in turn binds to other glycoprotein 2B, 3A receptors. And as you can see, this leads on to aggregation. So we have seen platelet adhesion, activation, and aggregation. And due to this, the injury in the blood vessel is being sealed off, resulting in the formation of a platelet plug. So in a nutshell, what we have seen is there's an injury, there's a collagen being exposed, the platelets coming and attaching either directly to the collagen or through the von Willebrand factor, resulting in activation of the platelets, release of the contents of the granules. The ADP comes and binds with the receptors which are present again on the surface of the platelets, resulting in the insertion of newer receptors on the surface, which binds to fibrinogen, resulting in aggregation. So this was primary hemostasis. Activation, adhesion, activation, aggregation, and this is the basic physiology behind the formation of platelet plug. Moving on to the next stage. Now, this platelet plug is an unstable state. It can break off at any minute. So we need to form a stable fibrin clot. So we move on to the third stage, that is the formation of the stable fibrin clot. Now, this fibrin is present in an inactive form called fibrinogen. The conversion of fibrinogen to fibrin is possible with the help of thrombin. Now, this thrombin again is present in an inactive form called the prothrombin. The conversion of prothrombin to thrombin is possible with the help of prothrombin activators, that is the factor 10A and the factor 5A. Now, there are two methods, there's two specific pathways by which this prothrombin activators are being formed, that is the extrinsic pathway and the intrinsic pathway. As you can see in the extrinsic pathway, it is mainly activated when there's injury to the tissues, leading on to the activation of factor 7, which again comes and activates factor 10. While the intrinsic pathway is when there is an internal injury, when the subendothelial collagen is being exposed, you have factor 12, factor 11, factor 9, factor 8, and the whole series leading on to the formation of prothrombin activators. So this is what is known as a coagulation cascade. What you see over here is a single event which triggers on a series of events leading on to the formation of fibrin, which is then converted into a stable fibrin with the help of factor 13. Now, how do you test the integrity of this pathways? How do you monitor the hemostasis? So three specific tests that is being used to monitor the hemostasis is, for the extrinsic pathway, we have the prothrombin time, which tests the integrity of the extrinsic and the common pathway. Activated partial thromboplastin time, which tests the integrity of the intrinsic and the common pathway. Common pathway alone, we have the thrombin time. So these are the specific tests which helps to detect monitor the hemostasis. Now, in the process of monitoring hemostasis, the researchers had accidentally stumbled upon pitfalls in this cascade model. Now, let's see what those pitfalls were. As you can see over here, these are the factors involved in the APTT test. Suppose there's a deficiency of factor 12. We expect to see the result as prolonged APTT. But when we see the presentation of the patient, we find that there's no bleeding in the patient whenever there's a prolonged APTT, if it is because of deficiency of factor 12. Now, if it is factor 11A deficiency, again, the result that we get, the lab results show a prolonged APTT, but the presentation of the patient is again different. They have variable bleeding. While if it is factor 9A or factor 8A deficiency, we have prolonged APTT, but with severe bleeding. Now, this shows that there should be certain pitfalls in the cascade model because the results all show the same, that is prolonged APTT, but the presentation of the patient varies. It can be either with no bleeding, variable bleeding, and severe bleeding. So this led researchers to consider that this must not be the actual pathway which is being followed in the body. So they moved on to a new model, which is called the cell-based model of hemostasis. Now, in the cell-based model, as the term indicates, cell-based, that is, we have cells playing a major role, and these cells are the tissue factor bearing cells and platelets. And it moves on through three stages, that is initiation, amplification, and propagation stage. Now, let's move through these stages. That is, we start with the initiation stage. So whenever there's an injury to a cell, that is, the tissue factor bearing cells are being exposed, like tissue factor bearing cells are fibroblast monocytes. Tissue factor is also being synthesized by the damaged endothelial cells. So whenever there's a damage to the blood vessel, these damaged cells express tissue factor on the surface. And what happens is factor 7 comes and binds to these tissue factors and gets activated. tissue factor bearing cells, you can see factor 7 coming and binding and getting activated. And once factor 7 is activated, it then goes and activates factor 10. And then we move on to the common pathway. That is 10 along with factor 5A converts the prothrombin into thrombin. So this is very much similar to the cascade model where we had discussed the extrinsic pathway where it starts with factor 7. So tissue factor bearing cells binds with factor 7, which activates factor 10, which along with factor 5A forms thrombin. Now the problem over here is a very small amount of thrombin is being formed, and this is known as a thrombin sparks. Now moving on from this initiation stage, we move on to the amplification stage. So when we move to the amplification stage, the activity shifts from the surface of tissue factor bearing cells to the surface of platelets. So this is again what is happening in the initiation phase, and we have only small amounts of thrombin being formed over here, which is known as the thrombin sparks. And we move the activity to the surface of platelets. Now what happens is the small amounts of thrombin which is present has multiple actions over here. It converts factor 11 to factor 11A. It activates factor 5 to factor 5A. It splits the compound, that is a factor 8 and 1 millibrand factor, and releases factor A and activates it. So now what do we have? We have an activated platelet with factor 8A, factor 5A, and factor 11A on the surface. So moving on to the next stage, that is a stage of propagation. Stage of propagation, we had the activated platelets with factor 11A, 8A, and 5A on the surface. What we see over here is factor 11A activates factor 9 to 9A. Now we have this compound, that is factor 9A, along with the factor 8A, which is known as the tenase complex. Now this tenase complex then activates factor 10 to 10A, which along with factor 5A acts as the prothrombinase complex, and this forms large amounts of thrombin over here. That is, prothrombin is being converted into thrombin. So we had the initiation phase where we had only small amounts of thrombin, which was known as the thrombin sparks. Then we had the amplification phase where the activity was totally shifted onto the surface of the platelets. And then we had the propagation phase where large amounts of thrombin formed will then help to activate fibrinogen to fibrin, leading on to the formation of a clot. We have this tenase complex activating, and then we have the fibrinogen, which is being converted to fibrin. And as you can see, the fibrinogen forms long fibrin threads, and this forms the clot. So these were the three pillars. So we had the initiation stage where we had small amounts of thrombin sparks. We had the amplification stage where this activity shifted from the tissue factor bearing cells to the surface of the platelets. And we had the propagation phase where large amounts of thrombin is being formed, converting fibrinogen into fibrin, and we have the clot formation. Now going back to our cascade model, now let's just compare our cascade model and our cell-based model. In cascade model, we had discussed that we had two specific pathways which work independently and they end on a common endpoint. So if that was a situation, if there was deficiency of any one factor in any of the pathways, the other pathway would have contributed. But that is not seen when we come to patient presentation of bleeding disorders. Both pathways can generate large amounts of thrombin to form clot. And here, coagulation factors are controlling the rate of coagulation. Now, in cell-based, what did we see? We started with the extrinsic pathway, which initiates the process and generates small amounts of thrombin sparks. This is followed by the intrinsic pathway, which works on the platelets to produce the thrombin burst. And as you can see over here, there's no role of factor 12 in the coagulation process, and that is why this could be an explanation for no bleeding seen in patients with prolonged APTT, which is due to factor 12 deficiency. Now here, cells are controlling the coagulation process. So this is how clot is being formed. Now, we move on to the next stage, that is the coagulation system. Once a clot has been formed, we have to Once the repair process takes place, we have to remove the excessive clot formation. So we move on to our anticoagulation system. The anticoagulation system is a form of tertiary hemostasis, that is the fibrinolytic system. We also have the endothelial cells, which play a role to prevent coagulation in a normal blood vessel. That is, we have the tissue factor pathway inhibitor, antithrombin, protein C and S system, nitric oxide, and prostacyclin. Now let's go through this one by one. The fibrinolytic system, we start with the fibrinolytic system. So we have already formed a clot over here. That is, the fibrinogen is being converted to fibrin. Now, by the process of fibrinolysis, once the healing process of the vessel is taking place, the fibrin clot is then being broken down to fibrin degradation product. Now, this is possible because of the role of plasminogen. The endothelial cells secrete tissue plasminogen activators, which convert the plasminogen to plasmin, and it is this plasmin which helps to break down the fibrin to fibrin degradation product. Now, our body has check systems. That is, it keeps in line all these activities, and check systems in the fibrinolytic system is plasminogen activator inhibitor, which prevents the excessive formation of tissue plasminogen activators. We also have the plasmin, which is being kept under check by the antiplasmin. Now, moving on to the other mechanisms by which random clot formation is being prevented in the blood vessels, we have the tissue factor pathway inhibitors. We have the tissue factor pathway inhibitors, which acts on the surface of tissue factor bearing cells, preventing the activation of factor 7 and factor 10. Anti-clotting system inside the vessels, we have, as you can see over here, heparin-like molecule, which is being synthesized by the endothelial cells, antithrombin 3, which helps to inactivate thrombin and factor 10A. We also have the protein C and S system, where we have the thrombomodulin, which is being synthesized by the endothelial cells. The thrombin, the excess thrombin binds with the thrombomodulin, which activates protein C. Now, this protein C, along with protein S, which is being secreted from the endothelium, inhibits the clotting by the cleavage of factor 5A and factor 7A. In addition to this, we have the normal endothelial cells secreting prostaglandin I2 and nitric oxide. Now, what is happening over here is this increases the cyclic AMP level. When the cyclic AMP level is increased, calcium is decreased, which decreases the release of granules from the platelets. So as you can see, we have the anti-clotting system inside the vessel, which keeps in check, preventing the random formation of clot in the blood vessels. So these are the regulatory pathways, that is anticoagulation. We have, this is our extrinsic, this is our intrinsic, and we have the common. And what do we see? We have multiple roles for antithrombin, which inhibits both the extrinsic and the intrinsic. Tissue factor pathway inhibitor, which keeps in check the factor 7 and factor 10. We have the protein C and S system, which keeps in check the factor 8 and factor 5. So what do we see over here? We are in a state of hemostatic balance. That is, we have two major systems, our coagulation system and the anticoagulation system. And in a normal state, this is in a state of balance. Now, what happens if the balance shifts towards any one direction? Suppose the balance shifts towards the coagulation system. This is when the normal physiological process of coagulation becomes into a pathological process. That is, there's formation of thrombosis and emboli, as is seen in stroke, myocardial infarction, and pulmonary embolism. The shift in the opposite direction, that is the anticoagulation system, results in random hemorrhages, that is hemorrhagic stroke and internal bleeding. So we see that in a normal situation, we are in a state of hemostatic balance. So physiology is all about homeostatic balance. So homeostasis and hemostasis forms a component of homeostasis. Now, just in a nutshell, what we had discussed, whenever there's a vessel wall injury, we have platelet adhesion aggregation, we have the coagulation cascade activation, thrombin, fibrin formation, stabilized clot, fibrinolysis, recanalization, and healing. So this normal physiological process is kept in balance with the help of activators and inhibitors. Now, the activators, whenever we have a vessel wall injury, we know we have already seen the von Willebrand factor coming and helping in platelet adhesion and aggregation. Sorry for that break in between. I think I was running at a bit more faster pace. So you got a time to process the information. So we'll go back to what we were discussing. The checkpoints in the coagulation in our body cascade. We have activators and we have inhibitors. So activators, whenever there's a vessel wall injury, the activators of the coagulation, we have the von Willebrand factor. We have a checkpoint over there, as you had already seen, the thrombomodulin and heparin-like substances. The coagulation cascade is being activated. You have seen all the factors involved over here for the cascade activation. And again, we have checkpoints over there. The fibrin formation, we have factor 13, which helps in the formation of a stabilized clot. For fibrinolysis, we have activators, that is tissue plasminogen activator, and we have a checkpoint over there, which prevents the formation. So based on this, we see that we are in a state of homeostatic balance. So physiology is all about homeostasis. So all systems in our body in a state of balance, and homeostasis also follows this balance system. It is not just in our body, also in nature. Everything in nature is also about balance. Thank you. Any doubts or any points that you would like to clarify?
Thank you, ma'am, for the very informative session. Now it's the time for questions. If you have any questions, please unmute yourself and ask. Another option is you can type your questions in the chat box, which will be answered. Yeah, I can't see any questions being asked. So if you have any queries, please do type them in the chat box. It will be answered later. So next, let me introduce our next speaker for today, Dr. Geeta Vidyadhar. Ma'am will be talking to us about the pre-analytical variables in coagulation. Before that, a few words on her. She serves as a consultant pathologist and head of hematology services in Karkinos Health Private Limited, Kochi. Ma'am did her DNB in pathology from the Institute of Pathology in New Delhi. Further, she underwent specialized hematopathology training at TMH, Mumbai. She is an ex-professor in the Department of Pathology, where she headed routine hematology, clinical pathology, advanced coagulation laboratory, and was also the consultant for flow cytometry services at the esteemed Amrita Institute of Medical Sciences, Kochi. Dr. Geeta ma'am's special areas of interest include malignant and benign hematology, flow cytometry, workup of bleeding disorders, and molecular hematology. Her dedication to these specialized areas reflect a commitment to advancing medical knowledge and providing exemplary patient care. A hearty welcome to you, ma'am. Please take over the mic.
Thank you for those kind words. I'll just share my screen. Give me a minute, I'll just Is my screen visible?
Yes, ma'am. Could you please
Yeah,
put
I'll
the
do that.
slideshow? Yeah, thank you.
So before I start, I would like to thank the organizing team for having invited me for this event and sharing the space with eminent people. And also, thank you, Biju Madam, for setting the ball rolling, which makes my work a little easy. I'll be dealing with pre-analytical issues that we encounter when we do hemostatic testing. So, sorry. Okay, I think the thank you was for the organizing team. So once we're thorough with the physiology, we get prepared to get the samples and start testing them to reach a diagnosis. So basically, the variables that we could encounter in an analytical test range from pre-analytical to post-analytical, and some data which says that the pre-analytical variables really have a big role to play when we look at lab errors. But here I would like to emphasize that the pre-analytical phase actually starts from the time the physician orders the test. So when we say pre-analytical and I project this data, maybe we all are alarmed to see that, oh my God, so much of errors. Huh? So this starts from the point where the physician orders the test. So that's what it encompasses. So as far as the laboratory activity is concerned, these would be covered under specimen collection, transport, stability till it reaches the lab, the processing of the sample, further storage. So these are the activities which we would be looking at how these variations in these activities may result in variations in our results. And also I would just give you an idea on the recommendations and guidelines on these points. So I would just also be sharing a few interesting cases which would help us understand the importance of following a proper protocol or a guideline. So why is it so important when we, I mean, if you have been to other meetings which discuss coagulation disorders, there's always a talk on pre-analytics, whereas you don't find that in other, say, pathology or other talks. That's because what we do in the laboratory is to detect a clot during testing. However, this clot, most of them being a clot detection method. So, but this process is not exactly what happens in vivo, and we just try to extrapolate this information and assess that this is something which is probably happening inside the body. And as Biju Madam has already emphasized that it's basically a physiological process, but apart from a bleeding disorder, it may get exaggerated or suppressed in many other systemic conditions also. So that makes our life a little difficult when we try to interpret abnormal tests. And more importantly, an error in our report can label a patient unnecessarily for lifelong with a lifelong diagnosis. For example, if we diagnose, we say that a particular factor is reduced, we may label him as hemophiliac. Or more commonly, when we analyze or when we put out a report on control of anticoagulation, we may trip the patient towards bleeding or thrombosis, either ways if we give the results on either sides. And also important that many of these pre-analytical errors are avoidable if we follow the guidelines and protocols. So we have a lot of factors which may interfere with our results. I would go into the common ones. So I'd just like to share a few cases which we encountered. when I was at Amrita. So we had this lady who had a dental extraction and had excessive bleeding following that. So that was controlled, that local hemostasis was achieved by giving a hemostatic suture. But then she needed a second extraction. So when she had this initial excessive bleeding, they sent the sample for basic screening, where they found that the PT was prolonged. So therefore, before the second extraction, they wanted to be sure that we have excluded a bleeding disorder. So the sample came to us. So the PT value was quite high against the control given in the brackets. So now the patient, we called in the patient for the history, because we also found the same values, similar values. The APTT was prolonged. So this patient did not have any significant bleeding history, no family history. We took another sample in our lab itself and retested it, and we found that in fact both PT as well as APDT were prolonged. So we were now stuck with somebody who wanted us to screen and tell them that the patient sample is, the values were within the normal limits and they could go ahead with the second dental extraction. But then we have not the initial, but an additional prolongation. So that's probably set us to think that maybe she has both pathways involved. So we went on, but meanwhile, since we were in the practice of taking a routine CBC analysis and the peripheral smear evaluation for all patients who come in for coagulation workup, we found this factor where the RBC count was high and therefore the hematocrit was also high, and which was prolonging this patient's values. So we corrected the citrate quantity and gave her the corrected tube and got the sample collected in that, which resulted in the actual value, which was normal for both PT and APT. So this is a common scenario which can happen. So having done this CBC analysis helped us in this case. So these are the two good papers which I would recommend for reading if anybody is interested. I would go on to another story, which is that of an old person who was admitted in the COVID ward with pneumonia and developed hemoptysis. So in lieu of that, his sample was also sent to us for workup, which showed prolongation of PT and APTT. So clinical diagnosis of a bleeding disorder, PT was prolonged, APTT was also prolonged. A repeat sample was requested, which also showed the same result. Again, this old patient also did not have any previous history of bleed or any family history of bleeding disorders. Now we thought we have to have some decision on this. So we ourselves went and got the sample from the ICU, which showed that this was the value. So we have two different samples, with one showing a prolongation of the screening test, and the second one which showed that this PT as well as the APTT were normal. So what happened in between was, when we traced the sample which came to us before from the ICU, it was drawn from a limb with an ongoing IV line, which diluted all the factors and it led to prolongation of the time. So this is also a common scenario which we encounter in a hospital setup. Now, yet another one, which is also very common, is that of when you get samples from an ICU, we often find that their times are prolonged. And in this case, in fact, we had this referred sample, which the baby had cephalohematoma, and therefore a routine screening was done, which showed that the APTT was prolonged, and they further went on to do a factor assay, which showed that it was only 20%. And the baby being diagnosed as hemophilia A. Now, this also did not have any family history or bleed from any other sites. A repeat fresh sample was requested. APTT was normal and factor rate was 100%. So here the error crept in because the sample was sent to the outside lab as a whole blood frozen sample, so which is not recommended. And probably also contributions from a difficult sampling, which happens in small babies. So these are my 3 cases, which we encounter very often, and these are situations which we can probably educate our clinical colleagues and the phlebotomist at the other end, and avoid them. Now, this 4th case of mine is an interesting one, which made us think a lot, investigate a lot, run around a lot, and fret a lot. So this was that of a 50-year-old person who had been on treatment for SLE, now came with thrombotic complications. She'd been diagnosed, she'd been having a prolonged APDT due to lupus anticoagulant 3 years back, done at our own lab. So that's the history. So I leave you with that history so that I can take the thread throughout this discussion and come to how we handle this case. You can think about this case, what could be the possibilities. As I go through, I will try to insert in between follow-up of this patient. So now when we discuss about pre-analytical issues, we need to have a clear understanding of what type of a patient we are evaluating, what type or types of samples do we require to come to an appropriate diagnosis, the type of vacutainer, the amount of blood, the method of transportation, what precautions do we need to take with regard to temperature maintenance, what type of sample processing methods are required, the type of testing, or if we require multiple types of testings, type of analyzer that we have in our lab, the quality control measures that we take, the result format, and importantly, what is our team consisting of. So as far as a patient is concerned, we really need to know whether we are going in for a monitoring or preoperative evaluation, which requires basic screening. If it is diagnostic, we may require screening plus further specialized tests along with a detailed history, which is always a very important pre-analytical factor that, as I've discussed in all the 3 cases, the point which led us to go after getting repeated samples and getting their values corrected was that none of them had any previous history or family history of bleeding. And recommendation that it is always better to include a CBC analysis and a peripheral smear evaluation when we are, at least for the diagnostic type of patient. So these are something additional which we may have to also consider is whether this patient is on some anticoagulant, antiplatelet, has a liver disease, or has some type of bleeding disorder that could be even acquired. Now, coming to the diagnostic team, I would say it essentially should consist of an integrated team which should have the clinician, the laboratorician, and the technical person who should be aware of the pre-analytical, analytical, as well as the post-analytical processes that we do with respect to coagulation testing. And in case of platelet function tests, the patient needs to be advised to have some preparations before phlebotomy is done. So that also should be aware, and the patient should be educated. And some instructions which may be given to the patient it is always preferable to get a fasting sample for all coagulation tests. The patient should refrain from smoking because it is said that smoking increases platelet aggregation, pushes our system into more of a procoagulant state. Consumption of caffeine, especially in platelet function disorders, is discouraged because it interferes with the fibrinolytic activity. Physical activity within 2 hours is also not recommended, and the sample collection may be done after the subject has rested for a short period. So, which can allay the anxiety. Now, coming to the type of needle which is recommended, preferably the diameter should be between 19 to 22 gauge. If in case we need to use a butterfly's needle, then the tube attached should be short, less than 6 centimeter, or the air volume being less than 5 microliter. And as far as possible, we should restrict the use of tonic to less than 1 minute, which may lead to some hemoconcentration or some start of some coagulation activities, and may increase the fibrinogen factor 7, 8, and 12. So this may not actually reflect in significantly in your test results, but it's good to know that this interferes. And it also may lead to activation of endothelial cells. Just a point to note that whenever we are doing a thrombin generation test, tourniquet should not be applied. Now, if the vascular access is limited and we are forced to draw sample through a butterfly device, we can use them, but with caution. If we use a butterfly device with an attached tube, then we may have to discard a part of the initial sample. And also careful with the IV catheters. If there is no other access, we may have to discard. Some of the recommendation coming as using a discard vacutainer, or we can probably discard volume of the IV catheter content and then start taking. And what should be avoided during phlebotomy is direct transfer from syringe to vacuole by piercing the rubber stopper. So this may induce a hemolytic process as the cells go and collide with the tube wall. And always use a siliconized glass tube or a polypropylene tube, not the plain glass tubes, which will again start the coagulation process by contact activation. So this is all about what we need to do with respect to the the needle and the other vacutainers. So it's always best to use the vacutainers, directly get the sample into the vacutainer, which has control pressure and will fill up to the adequate amount. So coming back to this patient who had been on SLE treatment and had an APDT which was prolonged 3 years back. Now she comes back, but we have this time tested her as negative. So that was a worry for us. So we'll see what happened to this patient as we go on. So now coming to the vacutainer, once we are done with the needle and the other precautions, vacutainer by CLSI guideline has to be sodium citrate 3.2%, 105 to 109 millimoles. So that is the one which is specifically being recommended. Previously, we were using 3.8% sodium citrate, which was better, which is seen to be better when we do monitoring for anticoagulation. So right now, the recommendation is to have 3.2% only. And the pH of the anticoagulated plasma has to be maintained at the prescribed level. So we need to get good quality vacutainer. So we have seen that we have had, I would prefer using a BD or a greener tube. Any other tube which is not valid, which if we want to use, needs to be validated and may give you trouble if we start to use them. So now why do we avoid 3.8 now is that it is it binds the calcium for longer times and prolongs the clotting times, and also gives a low fibrinogen. So what about EDTA or heparin? EDTA is both of them are very strong anticoagulants, and they would prolong the PT avidity, and they would give a falsely low levels for especially factors 5 and 8. Heparin contamination, this is another very, very common situation that we encounter in an inpatient setup, that you have a heparin flush that has been given just before taking the sample, which will spuriously prolong our values. So, and sometimes we get this clotted sample, and then you have only the serum to test. So there's nothing that is left. The sample is already clotted, and obviously all the screening times would be prolonged. So now how to know that your sample has been, suppose somebody gives you a EDTA sample and the plasma separated in a separated append-off. Then probably we can test and see that the potassium level is extremely high and the calcium being very low. So this would indicate that this is a EDTA contaminated tube that you have got. About heparin I've already discussed. So this would also lead to prolongation of the times, especially thrombin time is much more prolonged than the other screening tests. So for heparin, we can do the thrombin time, which is much, much more elevated. Apart from that, we may have to, it's not as easy as doing a potassium level for EDTA. There we'll have to go and get the history. So, so all this about heparin. So this is, some people recommend doing a factor 10 assay on that, which is not practically possible. So now this is just a summary of the pre-analytical recommendations for blood sampling, use of siliconized tubes, the citrate percentage, the pH to be maintained. Always check the labels and identify the patient. That is very, very important. A preferred collection with the vacutainer, and release a tourniquet and do not retain it more than 1 minute, and discard tube whenever it is required, and also respect the required ratio of whole blood to anticoagulant to whole blood 1:9. And how much should we fill? The recommendation is 90% of the vacutainer is the requirement. If it's a evacuated system, you will have the correct filling up to the mark, or we have to, if we don't have that system, then we have to fill up at least up to 90%. Roughly, you should see a very small area between the cap and the sample level. So that is rough estimation of whether it is adequate. So overfilling is allowed, but underfilling is not allowed, because that disturbs the blood anticoagulation ratio. So this is again some guidelines on what happens, or observations on what happens if we take a sample in EDTA, serum, partially clotted, underfilled, heparin contamination, etc. So, so going back to our lupus patient, we got another sample, but the same happened again. We got a negative results, which tried to change the reagent lot and rerun it, but it was of no use. We got the same result. So I would say while we take the sample, we should utilize the time while we are getting ready for phlebotomy. We should talk to the patient and get the history, especially history regarding any drug intake, especially the anticoagulants, antiplatelets, and also some history regarding any hormonal preparations that may be taken, especially for patients who come for menorrhagia evaluation, and also having to note that if the patient is pregnant, she may have a different reference range for the various coagulation parameters. So how much of the sample I've already mentioned, 90%, and very important, mixing of the sample 3 to 6 times complete end on end. So that is how we have to mix it before we process it. So this is same repetition of the same. Always check for clots and hemolysis or icterus. So this is the order of draw which we already all of us know, proposed by CLSI. And this is to prevent any contamination from a previously stronger anticoagulant into our coagulation tube. Back to the case, we still had no idea what we were encountering and why a positive patient now with even more thrombosis was coming as negative for us. So this is also point when we evaluate, when we take the sample, check for hemolysis, lipemia, icterus, and also a point on whether we should use a discard tube, which I've already discussed. So lysis of the cell membrane, which will start activation of the coagulation parameters. That's why hemolysis should not be. Hemolyzed sample usually is not encouraged for testing, but there are these days some coagulation parameters which would correct for hemolysis as well as icterus. Lipemic samples, that is why we recommend that we take a sample in the fasting mode so that the lipids can be controlled. However, if it is required, we may have to extract the lipids and then retest. That would give us the accurate values. Now, sample preparation, centrifugation is something that we do to prepare the sample. So the centrifugation is usually recommended at 15 to 25 degree room temperature. There is no need for using a cooling centrifuge. Ideally, they should have a swing out bucket system so that the plasma and the cell components do not go back and mix after we have done the centrifugation. Also, the centrifuge should have a break off mode. They should always be kept in a break off mode, because this also will, if you put on the brake, that will also mix the two components. Centrifuge should be validated every 6 months, and the recommended centrifugal force is 1500. If we go beyond that, it may induce platelet activation and hemolysis. So if you have a sample which is to be sent to a referral lab and there is a delay in transport expected, we can perform centrifugation, separate the plasma, and then send the separated plasma to the referral lab. So most of the times for most screening tests, we use platelet poor plasma, where we have spun it at 1500 G and separated it, and then we can transport it. Other specialized tests like lupus anticoagulant need a second centrifugation, but that should happen within 4 hours. For thrombin generation tests, it has to be immediately centrifuged. Double centrifugation takes care that the maximum number of platelets are removed from the system, so that since lupus anticoagulant is a phospholipid-based test, the phospholipids from the platelets are not contaminated. So that's why we do a second centrifugation. So PRP or platelet-rich plasma is usually used for platelet function tests. So there we spin it at a lower rate, 200 to 250 G for 10 minutes. At lower than 200, we do not get good results. So, and also during aggregation, we should not be trying to standardize the platelet values until it is about, till about 6 lakh, we can continue to use the same sample. So this is recommendation for centrifugation. All that I've covered is included in this. Now coming to sample stability, or aliquoted samples are stable for 4 hours. So samples which are for PT and INR usually give us a longer stability, about 24 hours at room temperature. Whereas for APTT, it is better to test within 4 hours. So the limited stability with respect to APTT is because of the role played by the labile factors, factor 8 and factor 5. And those where we need to test the APTT for the for evaluation of apparent therapy, that should be centrifuged in less than 1 hour and analyzed. So for long-term storage, we can freeze the separated plasma at 20 degrees C, which can very well go for about at least good for about maybe for a month or so. If we could store it at -80, it would go on for 6 to 18 months. So, and one more point, when we are taking out a frozen sample and doing the test, or suppose we are sending it out to a referral lab, we should freeze it very rapidly so that these proteins are not lost. Next point is, whenever we are taking out the frozen plasma and proceeding with the test, like suppose we have a batch testing, then we should make sure that the thawing of the plasma is done at 37 degree and at least taking 5 minutes. So, so that's about sample stability. For platelet function, the testing should be completed in 3 to 4 hours, but we should start testing once the sample is settled. We give some time to settle the sample, maybe up to 15 minutes, and the testing should be completed within 3 to 4 hours. So that's about sample stability. This is about freeze thawing, which is very important if we are doing batch testing. Transport of the samples should not be refrigerated or put on ice. It should always be transported at ambient temperature, and pH to be maintained. So the best thing that we do is, as soon as the sample is drawn, it should be capped so that there is no loss of carbon dioxide and the pH is maintained. And always transport the vacuoles vertically. And pneumatic systems are not to be used for platelet function, which will activate the platelets. And these are the guidelines for transport. And few more points before coming to inference. We should have normal reference ranges, and we should be aware that there are circadian and diurnal variations in some factors. We should also be aware that pregnancy as well as neonates have different normal ranges, and the ordering of the tests should not be randomly done and should not be overly done. Like we see a practice that for all thrombophilia, we start to testing processes even when it is in the acute thrombotic phase. So in acute thrombotic phase, most of the natural anticoagulants would be reduced, and it is not recommended. So we should, the test methodology, test panel should be selected according to the patient's history and the presentation, and a stepwise or a algorithmic based testing should be done. And these are the factors which will lead to specimen rejection: an underfilled tube, inappropriate tube, outdated tubes, hemolyzed tube, centrifugation issues, and pipetting of the plasma. When we do pipetting of the plasma, we have to be careful that we don't include the Buffy coat, so which will lead to contamination. So these are again. So, and also we should be mindful of our instruments like pipettes, centrifuges, and freezers. So finally, coming to our patient, we went back, we evaluated again how the samples went about. The phlebotomy was done in lab premises itself by our own staff. Sample quantity was adequate. No clots were found. Centrifugation was done at appropriate speed and time. Post-centrifugation, plasma was clear. So usually when you have hemolysis, it comes up in the post-centrifugation tube. We can see the tinge. Reagents were validated. QC was in place. Processing was done appropriately. But we found that the morning normal pool plasma run had some variation. And the next day we put all the samples in all the batches for platelet testing, which showed that some of the platelets or many of the samples had more than 30,000 platelet count, indicating that our centrifuge was out of calibration. So important message that our instruments have to be in good working condition and have to be calibrated at the prescribed times. So that's why we have to be mindful of our instruments also. So solutions, I would say, thorough understanding of the process of the testing by all the team members, good laboratory practices to be followed, good education of the phlebotomist, the specimen carrier, young clinicians, and updating them with the vacutainer and the amount of sample that is required for testing, and proper step-by-step evaluation and test ordering. So I think with that I would end and thank and you for your patient listening.
Thank you, ma'am, for the very informative session. Now it's time for questions. If you have any questions, please unmute yourself and ask, or you can type it in the chat box. Geeta ma'am, we have a question in the chat box. Ria has asked, why fasting is preferred in coagulation testing?
Yeah, that as I said, we would like to avoid any lipemic component.
Okay, thank you, ma'am.
I think there are some other questions also.
Yes, ma'am. There's another question by Aparupa. The question is, once we freeze the samples at -80, can we shift the aliquots from -80 to -40? Freezers.
No, it is not preferred. One more thing which I thought I have skipped is that we should not use the freezers which have automated defrosting system. So that till when you change the temperature from 80 to 40, there would be some degeneration of these proteins. So that is not recommended. Once you freeze it at 80, it should be at 80 till you do your test.
Okay, thank you, ma'am. Another question from Dr. Fawad. What are the commonest pre-analytic variables to be checked?
Yeah, when we have the sample in our lab, we should at least check the vacutainer, the amount, the any hemolysis, lipemia, all this should be noted, and very importantly, the history. I would say that all laboratory personnel should get the history from the patient directly, because when we get the sample only referred from the clinics, we don't have access to get a proper history. So these are the common things you can look at. And also the other end is that we should be ready to educate our phlebotomists or young clinicians, nurses who give us the sample.
Thank you, ma'am. So if anybody has any questions.
I think there is one more question. If we do thromboelastography, should the results come within 4 hours from the sampling, or the time limit No, for for TEG, we usually should process it soon. Because that is a fresh sample. So results are to be expected within an hour. I don't know why this 4 hours has come here.
Good morning, ma'am.
Yeah,
Ma'am, I have a query. Actually, in your first case, you have told about the increase in RBC count that may
yeah.
obviously affect the. So, uh, what should be the proportionate increase in the anticoagulant to combat this problem?
There is a formula. There is a formula by which you can calculate according to the percentage of hematocrit percentage. There is a formula. You can easily find it. I'm sorry, I could not put it in this slide, but there is a formula with which we can calculate how much amount of anticoagulant is needed for this much, say 55%, 60%, 65%. What is it? What is the exact amount of anticoagulant? So there is a formula which is easily available. You can derive that amount.
Okay, ma'am. Thank you, ma'am. In the in your second case, actually, for that COVID patient, why you repeated twice? Actually, why did you think it could be means a normal thing rather than any abnormality in that patient?
No previous history of bleeding.
That previous
That
history.
because
Okay,
of that point.
okay, ma'am. Okay, thank
So
you, ma'am.
obviously he had pneumonia and he had lung complications. That's why he had hemoptysis. He
Yes,
never
ma'am.
had any other bleeding, and he's old enough. If he had a bleeding disorder, he would have bled before also, no? So
Yes,
that's
ma'am. Yes, yes, ma'am. Thank you, ma'am. Thank you.
Thank you.
So I guess there are no more questions. Thank you, Geeta ma'am, once again for being a part of Cascade 2024. Moving
Thank you.
on to the next speaker. She is Dr. Kartika KV ma'am on the topic evaluation of bleeding disorders and algorithmic approach. Before that, is brief introduction on ma'am. She is a consultant hematopathologist in the Department of Pathology at Aster MIMS, Calicut. She earned her MD in pathology from Government Medical College, Kozhikode from 2012 to 2015, followed by DNB in pathology. She obtained her DM in hematopathology from the prestigious All India Institute of Medical Sciences during 2016 to 2019. She served as an assistant professor in the Department of Pathology and Clinical Hematology at AIIMS, Kochi from October 2019 to November 2021. Her areas of interest include coagulation disorders, hemolytic anemias, flow cytometry, bone marrow failure syndromes, myeloproliferative neoplasms, myelodysplastic syndromes, and molecular hematology. Her contributions and recognitions include being a reviewer for the Indian Journal of Hematology and Blood Transfusion. She was the quiz master for the ISHBT Zonal Quiz in October 2019 and the State ISHBT Quiz in August 2022. Kartika ma'am has also presented posters at the American Society of Hematology conferences in 2021 and 2022. She is also a speaker at the Pursue online PG lecture series for hematology. We are delighted to have you here, ma'am. Over to you.
Thank you. Thank you, Team Cascade, for having me again. I once again congratulate you for the successful conduct of Cascade in the year 2024. And I hope this continues further for the benefit of postgraduates. So today I'm about to speak on the topic, an algorithmic approach to bleeding disorders. Is my screen visible?
Yes, ma'am. Could you please put it? Yeah, thank you.
Yeah. So is my voice audible, clear?
Yes, ma'am.
Okay, thank you. Yes. So bleeding disorders have always been a challenge because there are a lot of tests involved, lot of types of disorders involved. So you're always in a fix what to test for first, how to approach a bleeding disorder. Now that is why we have an algorithmic approach wherein you have an yes or no kind of an approach to bleeding disorder. You ask a question, and depending upon the answer to that question, is the TT prolonged? Is the BT prolonged? So you ask questions, and based upon the answer to that question, you decide what other tests to do. So that's why it's called the algorithmic approach. This is created not only to ease the diagnosis of bleeding disorders, but also because you don't want to miss any disorder, because bleeding can be quite horrendous and quite difficult to treat, diagnose, and also quite difficult for the patient as well. So I'll try to make an effort to throw some light into this algorithmic approach. So what you want to do here is, when a patient comes with a suspected bleeding disorder, let's say he bled once or twice and he has a doubt whether he has a bleeding disorder. Now, this is what you are required to find out. Does he have a real bleeding disorder or not? Now, this is a big responsibility for both the treating clinician and also the diagnosing doctor, that is, we pathologists in the coagulation laboratory. So, therefore, we need to have a very meticulous approach, starting from the history and physical examination, followed by first testing and then an advanced testing. So this is going to be a team effort, starting from the clinics where the patient comes in first till the sample collection, running the sample, and then putting out the results. So let me discuss it along with the case. The case might not be related in certain areas, but it's okay just to make the talk interesting. So this was a 47-year-old gentleman who was a tailor by profession. He came with a painful swelling of leg. Obviously, the first differential was a deep vein thrombosis, and that is why he was referred to a hematologist. But the first investigation you do in a DVT is, of course, an ultrasound Doppler. But on imaging, it was found that the veins were actually patent. There was no thrombus within the vein as such, but there was a hematoma compressing on the vein. So how do you approach this patient? So as I told you, the first step in the evaluation of a bleeding disorder is the history and physical examination. Now, what are the points that you need to focus in this area? First will be the type and frequency of bleed. Now, you need to ask the patient what kind of bleeds he had in the past, what kind of bleed he has now, and how frequent the bleeding was. Now, this will help us to understand certain things. For example, if the bleeding is mainly from the mucosal membranes, like your skin, like petechiae, ecchymosis, bruises, or teeth bleed, circumcisional bleed, or such bleeds which involves the superficial membranes, mucosal membranes, it is likely to be a defect in the platelet, because we know that in the normal physiology of coagulation, the first fighters who come in whenever there is a bleed is the platelet. So whenever there is a superficial bleed, like in the mucosal membranes, the platelets have a pivotal role in arresting this kind of bleed. And if the platelets are deficient or defective, the patients present with mucosal bleeding. And also, these patients have immediate bleed, because for the same reason that the platelets are the first to come in whenever there is a bleed. These patients, the patients with platelet defects, they have immediate onset of bleeding. Whereas in coagulation factor deficit, these patients present with deep bleeds, like in the muscles and the joints. They have large hematomas, and they are delayed in onset because coagulation factors come later in the cascade of normal hemostasis. So your first hemostatic plug is formed by the platelets, followed by a secondary hemostatic plug formed by fibrin or the coagulation pathway. So that is why any defect in the coagulation pathway causes a late onset bleeding. Now, this kind of history can give you an idea as to what kind of defect you are likely to see in a patient. So these are all ecchymotic patches, superficial bleeds. These are also large ecchymotic patches. Now, this is a deep bleed. This is a psoas bleed, classically seen in patients with hemophilia, especially in muscles and joints, which are put into a lot of tension and friction. These muscles and joints are the ones which are most commonly affected in hemophilia, and this CT shows bleed within the psoas muscle. This is a joint bleed, classically again seen in hemophilia patients. So this kind of history is first important. Also, certain classical red flag histories like your excessive bleeding following circumcision, surgery, tooth extraction. These are all seen in platelet defects. Umbilical stump bleed, which can be seen in fibrinogen deficiency and classically factor 13 deficiency. Muscle joint bleeds seen in coagulation factor deficiency. CNS bleeds again seen in fibrinogen deficiency, factor 10, factor 5 deficiency. Recurrent miscarriages, again in fibrinogen deficiencies and factor 13 deficiency. Delayed wound healing, again, is a classical history which you get with fibrinogen deficiency, because wound healing also requires that you have a fibrin clot forming so that the granulation tissue can grow upon it. So patients with congenital deficiency of fibrinogen present with classical defective wound healing history. So it is important that you ask for these specific histories as well, because they are specific for particular bleeding disorders. The next important history which you need to ask for is whether the bleed was provoked or unprovoked. Was there any provoking or triggering factor for the bleed? Now, what information does it give you? It gives you an information about the severity of the disease you're dealing with. Now, this is a pyramid which actually tells you the prevalence of different bleeding disorders. Now, bleeding of undefined cause. This is something which we encounter in our everyday practice. Now, these kinds of bleeding have increased prevalence. They have very less severity and they have very high diagnostic difficulty. Now, this is going to be the area where you have the most trouble, because they are the most common patients. They have one or two bleeding episodes and they are not amenable to diagnosis as well. These are likely to be due to local causes, but however, sometimes these are the patients which form the biggest burden for a hematologist as well as the diagnosing histopathologist. So these group of patients have to be asked for very insignificant histories as well as to whether there was any bleeding in the childhood or in the past. And also then followed by your type 1 von Willebrand. Type 1 von Willebrand, though it is a specific bleeding disorder, it tends to be missed because the bleeding severity is very less. So this again requires a very meticulous history taking. You need to ask for history of any menorrhagia in particular, any bleeds during small surgeries, dental extractions, etc. And as you go up the pyramid, it becomes easier because the patients have much severe bleed and they have very specific defects as well. And therefore, the diagnosis becomes very easy in them. So to reiterate, the base of the pyramid is the most difficult to diagnose, and you might always not get an answer in these patients. So what if the symptoms are mild? How do you actually decide whether to test these patients or not? Now, for this sake, there is something called a standardized bleeding questionnaire. Now, why do you have to have such a questionnaire? Because one practitioner might think that his bleeding is significant, he needs further testing. One practitioner may think, oh, he has a single episode of bleeding, just leave it, why bother? So in order to objectify the bleeding history, we need these standardized scoring systems. Now, there have been several scoring systems which have been made since 2005, starting from the Vicenza. BAT stands for Bleeding Assessment Tool. So Vicenza BAT was the first one introduced in 2005, mainly for the diagnosis of von Willebrand disorder. This was followed by the MCM-DM1, von Willebrand disorder BAT. Now, most of the BATs are designed for BAT because, as I told you, They are the specific bleeding disorders which are difficult to diagnose because their symptoms are very mild and non-specific. Then right now, the most commonly used questionnaire is the ISTH-BAT, or the International Society of Thrombosis and Hemostasis BAT. Now, this is a very easy scoring system to use. This might take around 20 to 30 minutes to administer, and this can be done on the website as well. Now, all these BATs have particular ranges. For example, ISTH BAT, the normal for a female is 5 or less, for a male is 3 or less, for a child is 2 or less. Anything above this warrants investigation for a bleeding disorder. Now, what are the different components of this bleeding disorder tool? Bleeding assessment tool, you have 14 different symptoms like epistaxis, cutaneous bleeds, bleeding from minor wounds, wound cavity, etc. And then every one of these bleeding symptoms are scored from 0 to 4. 0 means that it is very trivial. 4 means it required significant intervention. Like, for example, if it is epistaxis, 4 is degree of bleed which requires blood transfusion or replacement therapy, meaning that the bleeding is quite significant and therefore requires a workup. So another important significant feature of the ISTH BAT is that it gives quite a lot of importance to menorrhagia. It is a symptom which is disregarded in females, and therefore, ISTH BAT is good in a way that it gives importance to menorrhagia and brings in patients with this significant symptom into the workup of bleeding disorders. So after you look for the degree of bleeding, the severity of bleeding, you then go into the next history, that is asking for any type of treatment that they would have received in the past. Like, for example, they received plasma or they received a nasal spray like desmopressin. So now how is this going to be? Example, if the patient has received plasma, it means that he had some deficiency or defect in the coagulation proteins. If the patient received platelets, it means the defect was in his platelets. If the patient received desmopressin, it means the defect was again somewhere in the von Willebrand system, because von Willebrand factor is released from its storage under the influence of desmopressin. Therefore, patients with mild von Willebrand disease can be treated with desmopressin. So this can also help us to touch on the diagnosis. The next important history we need to look into is the family history, because in inherited bleeding disorders, we have 2 modes of inheritance: X-linked recessive inheritance and autosomal dominant inheritance. X-linked recessive inheritance we see in hemophilias, wherein usually boys are affected, and the family history comes from the maternal side. The mother is usually a carrier. She may or may not have symptoms, but the history specifically you need to ask for is from the maternal uncles and the children of maternal aunts, the sons of maternal aunts. Another common inheritance in bleeding disorders is autosomal dominant, seen in von Willebrand disease, where one of the parents might have a significant bleeding disorder. Now, this family history may be negative in autosomal recessive types of inheritance, and also sporadic mutations or new mutations, especially in hemophilia. 2/3 of the case are only inherited. 1/3 it might not be inherited, where sudden sporadic mutations may come in a particular generation. And in such cases, the mother might not harbor any carrier mutation. Family history may also be negative in acquired disorders. Now, this absence of family history is also important in diagnosing a bleeding disorder, because it enables us to look for either an inherited or an acquired disorder. And the next most important history is the drug history. As we were talking in the pre-analytical errors, drug history is a dual masked enemy. It can not only cause increased bleeding and mimic a bleeding disorder, it can also mask bleeding and affect diagnosis of bleeding disorders. So there are several classes of drugs which can cause bleeding, like your anticoagulants, antiplatelets, and drugs used for other disorders. And there are certain drugs which affect testing for bleeding disorders. To list a few, platelet aggregation is one common test which is affected very much by certain drugs and non-drug agents like your garlic, green tea, etc. So all this has to be avoided when you are planning to test a patient for platelet function. Okay, so now you have taken all the history. Now, how will you decide? The patient comes in with a suspected bleeding disorder. He has normal bleeding history, nothing significant, no signs of bleeding. You can say it's safe to say that the laboratory screening is not recommended in some patients, such patients. But however, if the patient has any abnormal screening test which was done routinely or pre-operatively, even in the absence of a significant bleeding history, workup is warranted in these patients, because some bleeding disorders, they manifest only when the patient has a hemostatic challenge, like during surgery. So you don't want the patient to bleed during surgery. So you need to work up the patient and make sure that the patient doesn't have a bleeding disorder. And you need to understand why the screening test is abnormal before you take that patient to surgery. Another situation where you would test the patient in the absence of a bleeding history is when there is a significant family history. The other scenario where you would like to test the patient is if either the bleeding history is abnormal or the physical examination is abnormal, you are warranted to look for a possible bleeding disorder, and therefore you need to go on with a laboratory screening. So in our patient, history was quite insignificant, non-contributory. There was no previous history of bleeds, no family history, no drug history. Mother had a history of menorrhagia, which had resolved with hysterectomy, likely to be due to local causes like a fibroid or endometriosis maybe. He had no positive blood group. Now, blood group assessment is important whenever you're taking history of the patient, because certain coagulation proteins like von Willebrand factor levels, they vary depending upon the blood group of the patient. So it is always important that you record the blood group so that you can assess the normal levels accordingly. Okay, so what next? Is a patient a bleeder or not? You're still not sure. He has had one episode of bleeding, that too in the leg, a soft tissue bleed. Does he need workup? Still, I don't have an answer for that. But what happened was, because he was a case of DVT, they actually thought of starting heparin outside even before imaging. And luckily, they had done an APTT, but that APTT was prolonged. It was in the order of 56 seconds. Now, this falls into an abnormal screening test, and therefore, this patient had to have a laboratory screening in place. So, what are the screening tests you do? See, screening tests, you can increase the list as much as possible depending upon the resources of your lab, depending upon the number of patients you see. But these are the usual screening tests: complete blood test, peripheral smear examination, PT, APTT, thrombin time, fibrinogen and D-dimer if DIC is suspected, mixing study, PFA 100. Now, this is quite an exhaustive list, but if you have to restrict this list, you might do a complete blood count with peripheral smear examination, a PT, APTT, a fibrinogen, and a mixing study. Thrombin time is going to reflect basically your fibrinogen activity. D-dimer might be added if you're clinically suspecting a DIC, and PFA 100, the role of a PFA 100 in the screening of a bleeding disorder is still very controversial. So let's do a CBC and peripheral smear. If your platelet count is normal and you verify that on your peripheral smear, proceed to the next test. However, if your platelet count is low with giant platelets, you look in for these things. The gray platelets. So the gray platelets are pale staining platelets, which you see on the peripheral smear on Giemsa stain smears, and this is indicative of your gray platelet syndrome. You also need to look for aggregates like these. Okay, so your platelet count may be spuriously low because of platelet aggregates. Platelet aggregates can also indicate certain diseases, like in your von Willebrand type 2B, where there is increased binding of von Willebrand to the platelet. You can actually see clumps on the smear causing thrombocytopenia. You also need to look for neutrophil inclusions, Dole body-like inclusions within the neutrophils, which may be associated with giant platelets in your MYH9 associated platelet abnormality, like your May-Hegrin anomaly, Sebastian anomaly, Epstein anomaly, etc. So these are the things you need to look for whenever you see giant platelets. And you proceed with platelet function testing on von Willebrand testing if you're suspecting a von Willebrand disease type 2B. If the platelet count is low with normal to large platelets. Now, giant platelets is something larger than the RBCs. Large platelets is something equal to or less than the size of RBCs. Now, if you see this, if you're looking for an inherited cause, if the patient has a family history, if the patient has a very long history since childhood, you still look for a platelet function defect. But if it's an acquired disorder from your history, you then need to look for all other acquired causes of thrombocytopenia, like your ITP, DIC, chronic liver disease, malignancy, and the other clues you need to look for in the peripheral smear are your schistocytes, any abnormal leukemic cells, evidence of hemolysis like polychromatophils or NRBCs, etc. So this was about the CBC and peripheral smear. So once your platelet count is normal and morphologically they appear normal, then the next screening test which comes in your flowchart is PT, APTT, and TT. Now these times actually assess the integrity of your coagulation pathway. Now this is the traditional cascade pathway. The cascade of coagulation, wherein there are two pathways, the intrinsic pathway and the extrinsic pathway. The intrinsic pathway starts with factor 12 and the extrinsic pathway starts with factor 7. They culminate in the activation of factor 10 from where your common pathway starts. Factor 10 in the presence of 5A calcium phospholipid converts prothrombin to thrombin. Thrombin then acts on fibrinogen to produce a fibrin clot. So APTT assesses the functioning of the intrinsic pathway from factor 12 till the formation of your fibrin clot. Similarly, your PT or the prothrombin time assesses the integrity of your extrinsic pathway starting from factor 7 till the fibrin clot. The TT or the thrombin time assesses the single step, that is the conversion of fibrinogen to fibrin. So if your thrombin time is prolonged, it is almost always got something to do with defects or deficiency of fibrinogen after excluding heparin contamination. Okay, so if your PT and APTT both are prolonged, it means that your common pathway is affected because these proteins are common in both the intrinsic and extrinsic pathway, and therefore it means that your common pathway is affected. Now, I'm not going into the details. We all know how you do a prothrombin time, an activation partial thromboplastin time, and a thrombin time. This can be done manually as well as in a machine. Prothrombin time is actually the time taken by recalcified plasma to clot in the presence of a tissue factor and phospholipid. Why do you have to add a tissue factor? Because tissue factor is something which triggers or activates the extrinsic pathway. Similarly, in activated partial thromboplastin time, the triggering factor is your cellite or silica or ellagic acid. It's a surface activator, negatively charged contact activator. So if you add tissue factor, it becomes specific for prothrombin time. If you add a contact activator, it becomes specific for an activated partial thromboplastin time. If you add excess of thrombin, it becomes a thrombin time. Here you do nothing but you add excess of thrombin and you calcify the plasma and record the clotting time. So these tests are very easily performed, but care has to be given to both pre-analytical errors and also pipetting errors. So once you have done your clotting times, that is PT, APTT, and TT, if any of these times are prolonged, then you need to follow it up with a mixing study. Now, I think this has to be a reflex. After Cascade, I hope the take-home message will be to do a mixing study whenever you see an abnormal PT, APTT, and TT. Now, there might be situations where you have an explanation. For example, a patient in the ICU with a prolonged PT, a patient with liver disease with prolonged PT. Now, here you know why the PT is prolonged. But in a patient with bleeding disorder who's coming for workup and his PT or APTT is prolonged, it is absolutely not justified if you don't do a mixing study, because mixing study is something which can be easily done and it gives a whole lot of information, not only about the type of disease you're dealing with, but also how you can actually manage the patient if he has some bleed. So what is a mixing study? In the mixing study, you take equal volumes of the patient's plasma and a normal pooled plasma. So as I already told you, these times, there's a prothrombin time, APTT, TT, all these are used to assess the integrity of the coagulation factors. So when you're adding an equal amount of normal plasma, you're actually providing the factors in excess. So if the patient has an actual deficiency of the factors, this mixing will correct the abnormal times. Like for example, if the patient's PT is prolonged, you add in normal plasma. If the patient has factor 7 deficiency, the normal plasma will replenish the factor 7 deficiency. And if you repeat the PT on this sample, it will be corrected. But if the patient has an inhibitor rather than a deficiency, how much ever normal factor you are going to provide in the form of normal pooled plasma, this inhibitor keeps inhibiting the normal factor and your PT will not get corrected. So this is the basis of a mixing study. So if you have a PT or an APTT or a TT prolonged, it is absolutely warranted to do a mixing study and assess the correction or non-correction. A correction means that we are dealing with a deficiency. A non-correction means that we are dealing with an inhibitor. So now that I have told you about the basics of these tests, let's see what are the specific causes of prolongation of these tests. Now, let's say you do a PT, the PT was normal, then you go in with APTT, but if the PT is prolonged, isolated prolonged, you have to do a mixing study. If the mixing study is corrected, obviously you will look for an inherited or an acquired cause. If it is inherited with the factor 7 assay, if it is an acquired cause, that is a recent onset of symptoms and the patient has a liver disease, patient has some other chronic illness, then you look for acquired causes of vitamin K dependent factor deficiencies, in which most commonly PP is prolonged first. Okay, in the later stages of vitamin K deficiency, your APTT will be prolonged, but initially your PT is prolonged. So you need to rule out DIC, liver disease, and warfarin therapy in acquired causes of isolated PT prolongation, which corrects on itself. If it is not corrected, you are dealing with an inhibitor, which is likely to be a factor 7 inhibitor. Do a factor 7 assay followed by an inhibitor titer. If your PT is normal, go on to an APTT. If your APTT is again normal, then you have got a scenario where your PT, APTT, and platelet count is normal. Let's deal that separately. Coming to a scenario where your APTT alone is prolonged, isolated prolongation of APTT, again going for mixing, look for correction, whether it's corrected or not. If it is corrected, go into the history, go back to the history and see if the patient has bleeding. Now, why do you have to ask this history? Because if the patient has bleeding, it is likely that they have a deficiency of factor 8 or factor 9 or a von Willebrand disease. Now, how can a von Willebrand disease cause prolongation of APTT? Because we know that von Willebrand factor has a function of carrying factor 8. So if a von Willebrand factor is deficient, automatically your factor 8 will also be deficient, and this will contribute to the prolongation of APTT. So whenever you are working up a patient for isolated prolonged APTT, you need to remember that von Willebrand disease also has to be looked for. Now, these patients present with bleeding. Now, is there a scenario where your APTT is prolonged, it's corrected on mixing, but still the patient has no history of bleeding? Yes, it is possible. It can be seen in factor 12 and factor 11 deficiency. Remember, these are components of the intrinsic pathway. So any deficiency of these factors can cause prolongation of APTT. However, these coagulation proteins deficiency do not cause bleeding. So therefore, a bleeding history may not be elicited in these patients. Now, what if your APTT mixing study is not corrected? Again, you see whether it's an inherited cause or an acquired cause. Inherited cause, it could be inhibitors in patients with inherited hemophilia A and B. Now, we know hemophilia A is a condition where the patient has deficiency of factor 8. These patients take factor 8 for therapy, recombinant factor 8 for therapy, and over time they start developing inhibitors towards these transfused proteins. So this could be a cause wherein you see lack of correction of APTT in a known case of hemophilia. You go in with an inhibitor screen and a Bethesda assay. Now, if you're looking for an acquired cause, you need to remember that there are two causes, a lupus anticoagulant and an acquired hemophilia. The most common cause of a non-corrected, isolated, prolonged APTT is lupus anticoagulant. But these patients usually do not present with bleeding. These patients have a thrombosis history. So lupus anticoagulant is something you test for in patients with unexplained thrombosis. So now let's say a patient comes with thrombosis, you do the APTT, it is prolonged, and on mixing, it is not corrected. You will then test for lupus anticoagulant specific testing, like your DRBBT or your kaolin clotting time, etc. Another scenario where your APTT is not corrected on mixing is acquired hemophilia, which is an autoimmune disease where patients develop antibodies to native factor 8, and therefore the mixing study does not get corrected. Here again, you will need to do an inhibitor screen and a Bethesda assay. What if all your parameters are normal? PT, APTT, and platelet count are normal? You still can have a lot of bleeding disorders in this category. Factor 13 deficiency, platelet function disorders, and mild von Willebrand diseases, which are not associated with reduced factor 8. These can also present with normal screening tests. Now, how do you assess these patients? Based upon the history, based upon what you're suspecting, you need to work it out with a urea solubility test, a platelet function testing, or a von Willebrand factor test. Now, what if both your PT and APTT are prolonged? Here, you go in for thrombin time testing. If your thrombin time is prolonged, rule out a heparin contamination. After ruling out a heparin contamination, the only thing you are left with is disorders of fibrinogen. Now, this disorder can be qualitative or quantitative. Now, if it is quantitative, it is either called afibrinogenemia or hypofibrinogenemia. If it's qualitative, it is called dysfibrinogenemia. You need to do both antigen assays and functional assays to diagnose these types of fibrinogen defects. If your TT is normal, thrombin time is normal, again do a mixing study. If it is corrected, again, if it is an inherited or an acquired cause. If it's an inherited cause, it could be deficiency of any of the common pathway factors, that is factor 2, 5, and 10. If it is acquired, again, you need to rule out all your acquired causes of coagulation factor deficiencies like BIC, liver disease, and vitamin K. If it is not corrected, we need to think of any common pathway factor inhibitors. Now, these are all you don't have to mug up these flowcharts as such. You just have to think. You need to keep the pathway in mind, and you need to keep in mind the fact that the correction in the mixing study depicts a deficiency and a non-correction depicts an inhibitor. So let's discuss a few slides on how you work up a patient with normal screening tests. Now, I had already told you the causes for scenarios where you have normal screening tests. So one test which can help in this area is your PFA 100. Now, PFA 100 stands for Platelet Function Analyzer 100. Now, this is a kind of a point of care mission where you have cartridge coated with platelet agonists, and you allow whole blood to flow through it, and you actually see the closure time. So since the cartridge is coated with agonists, there is a hole in the center of this cartridge and blood flows through it. While flowing through it, it comes in contact with the agonist, the platelets get activated and they start aggregating in this hole, and the hole gets closed. So the aperture closure time is what is measured in the PFA 100, and this time reflects the aggregation capability of the platelet. Now, this is for theoretical purposes. Of course, it is a screening test, but even in the presence of a normal PFA 100, we cannot completely rule out a mild platelet function defect or a von Willebrand factor defect. This is more commonly used to assess the action of drugs like aspirin and clopidogrel. It is more useful in such scenarios. Now, another test where you assess platelet function is by light transmission aggregometry. This is a technique wherein you measure the transmission of light. So in resting platelets, now resting platelets are dispersed here and there, and they are not aggregating. So the aggregation is 0%. Then you add an agonist. Agonists are stimulants which stimulate platelet activation, like your thrombin, collagen, arachidonic acid, epinephrine, ADP. These are some of the agonists which we use for testing. So once you add the agonist, the platelets get activated. Once the platelets get activated, they start changing the shape, and then they start aggregating, causing a change in the percent of aggregation. Now, this is measured in real time and plotted as a graph. This is what is seen in your platelet function testing. You actually see how much of light is being transmitted, and which in turn is inversely proportional to the aggregation happening in the sample. And then based on the plot or the graph, you diagnose different diseases. In Glanzmann's thrombasthenia, you don't have a curve in most of the agonists except for ristocetin. In Bernard-Solia, it is the straight inverse, wherein you have an aggregation in response to all the agonists except your ristocetin. Now, I'm not going into the details. This will be discussed in detail in other sessions. I'm just putting a word on the investigations which are available to diagnose these patients. The next technique we have to diagnose these patients is flow cytometry, where you quantitatively look for the presence of platelet receptors on their surface. For example, in Glanzmann's thrombasthenia, you look for the presence of CD41 and 61. In Bernard-Solia, you look for the presence of surface 42B. So that was about platelet function testing. Now, von Willebrand disease testing, now it requires a session on its own, because there are many types of von Willebrand disease. There are both quantitative and qualitative defects. Quantitative defects are type 1 and 3. Type 1 is partial deficiency, type 3 is complete deficiency. And again, you have the qualitative defects, 2A, 2B, 2M, and 2A. In each type, the defect is different. Now, just a few words on how you diagnose this. If it is a quantitative defect you are dealing with, you just need an antigen level. So if the antigen level is 0, it is type 3. If it is somewhere between 30, around 30 and less than that, then you call it type 1. But if you're suspecting a functional defect, then there your antigen levels will be normal. So you need a functional level, which is measured by the ristocetin cofactor activity. And this is what is used for type 2 von Willebrand disease. You measure the ratio of the ristocetin cofactor activity and the antigen. That is the functional versus the quantitative levels. And the ratio of less than or equal to 0.6 indicates that there is a qualitative defect in von Willebrand disease. So that was about the workup of von Willebrand disease. Coming to our patient, we did the screening test. Platelet count was normal. Prothrombin time 13.4, normal. APTT was of course prolonged. It was 63.2 seconds. Thrombin time was normal, 16.4 seconds. Fibrinogen was normal, 67.7 milligram per deciliter. On mixing study, obviously we did an APTT, it was prolonged, so we had to go for a mixing study. There was no correction. So as I told you, the most common cause of a non-corrected, isolated, prolonged APTT is lupus anticoagulant. So it was natural that we go in with a lupus anticoagulant testing, though this patient had a bleed. The lupus anticoagulant was negative. So we have a patient with prolonged PTT, not corrected on mixing, possibly acquired. Now this I say from the history because he has never had any past history of bleed, never reported a family history. His lupus anticoagulant is negative and no thrombosis. Now let's go back to our flow chart. We are going to be somewhere over here. Acquired, not corrected. So the two causes were lupus anticoagulant and acquired hemophilia. Now that we have ruled out the lupus anticoagulant, we are left with acquired hemophilia. And so therefore we went ahead with the factor assay. Factor 8 was 23 international units per deciliter. It's low. Factor 9 was normal, 112. The Bethesda titer was 128B. And therefore this patient had an acquired hemophilia A. Now why we didn't miss this, of course, we picked it up because of this algorithmic approach. Now, acquired hemophilia A doesn't have a past history, doesn't have a family history. The patient presents with an isolated prolonged APTT, which doesn't correct on mixing. And the patient presents with bleeding. Okay, so this is why the history, the screening, and the advanced testing, everything is equally important in the workup of a bleeding disorder. So this brings me to the end of my talk. A step-by-step approach from the moment the patient climbs into the clinic is really important in the workup of a bleeding disorder, and that will alone help us to put the jigsaw in place. So it's not a big Herculean task. It just requires a little time and care and thinking and specific focus to the history, the physical examination, and the laboratory testing. So thank you for giving me this opportunity, and thank you for your patient listening. I can take any questions if you have.
Thank you for the wonderful session, ma'am. So if anybody has any questions, please raise your hand and ask, unmute yourself and ask, or you can type the questions in the chat box.
Okay. Can you tell me more about the Bethesda study? Yeah, I can tell you more about the Bethesda study, but I need another half an hour. Okay, so Bethesda study is wherein you have the patient's plasma. The patient's plasma has an inhibitor. So let's say it was a factor 8 inhibitor, and the patient has an inhibitor. So what do? You add normal plasma to that patient's sample. Okay, and you see how much of the factor VIII in the normal plasma is being inhibited by this inhibitor. So the titer of the inhibitor, which reduces the factor VIII in the normal plasma by 50%, is the Bethesda assay. So if I tell it out of the blue, you're not going to basically understand. You're actually quantifying the amount of antibody in the sample. So herein what you do is you serially dilute the normal plasma and you add it and you measure the factor VIII activity. Okay, so the factor VIII activity keeps reducing proportionately. You plot a graph and based upon the fall in the factor VIII, you assess the Bethesda titer. Now, I'm sure you're not going to understand. Maybe organizers, if you want, I can talk on Bethesda study some other time, but it requires more time to explain. In one line, it is basically a study wherein you assess the factor VIII activity of a normal pool plasma after adding it to the patient's plasma, and the fall in factor VIII activity actually gives you the titer of the factor VIII inhibitor. Next question, can you please explain PFA 100 principle again? Okay, platelet function analyzer. So it actually has a cartridge, okay? A cartridge which is coated with platelet agonists. It can be either ADP epinephrine or ADP collagen. These are the platelet agonists. And it has a hole in the center. Now, what do? You allow blood to flow through this hole continuously. Just like in your body, the blood flows. The blood is allowed to flow through the hole in the cartridge. Now, because the cartridge is coated with agonists, the blood comes in, the platelets in the blood comes in contact with these agonists and they get activated. So collagen, ADP, epinephrine, whatever it is, they get activated. Now, once they get activated, the platelets undergo activation, shape change, aggregation, everything. And at the point of contact with the cartridge, that is near the aperture, these platelets aggregate and the aperture closes. And this aperture closure time is measured by the machine because once the aperture closes, the blood doesn't flow, right? So once the aperture closes, you get a value called the aperture closure time, which is in seconds. So based upon this time, you see whether the platelets are okay or not okay, etc. It's just a screening test to see the platelet function.
Ma'am, we have another question. If
Yeah.
PT-INR is normal, but APTT is abnormal, what should be done? The patient is bleeding. It could be due to some other cause. There are no further tests are possible, whether to give FFP or not.
Mixing study is possible. See, you need to definitely do a mixing study in this scenario, especially because you want to know whether you want to give FFP or not. If you're dealing with an inhibitor, giving an FFP is not at all going to help. The patient will continue to bleed because whatever factors are there in the FFP will be inactivated by the inhibitor in the patient. So please do a mixing study. If there is correction, you can help the patient, bleeding patient, by giving FFP. If there is no correction, you will have to look for an inhibitor, and no amount of FFP is going to help the patient. Yes. Verify now. Verify now, I think, is another card-based testing. I have not seen it being used as a screening test till now. I mean, I have never used it as well. So anybody in the group has an experience, you can share.
If anybody has any questions, could you please unmute yourself and ask? I guess there are no more questions. So thank you so much, ma'am, for giving a wonderful talk.
Thank you. Thank you.
So our next session will start at 11:15. It will be by Dr. Deepak Charles, sir. Hello, everyone. Deepak sir has joined us. So our next speaker for today is our beloved Dr. Deepak Chal sir. He will be speaking on the topic inherited bleeding disorders, diagnosis to management. Before that, a short introduction on sir. Dr. Deepak Chal sir is a consultant in hematology and stem cell transplant at Aster MedCity, Kochi. In addition, he serves as a visiting consultant in hematology here at JMMCH, Thrissur. Sir has pursued an illustrious academic journey, which includes MBBS from Government Medical College, Thrissur, MD in General Medicine from Government Medical College, Calicut, DNB in General Medicine, DM in Clinical Hematology from JIPMA, Puducherry, and his expertise is further enriched by specialized training in Department of Clinical Hematology and BMT at CMC Vellore, and in the Department of Clinical Hematology and Hematopathology at AIIMS, New Delhi. Dr. Deepak sir has contributed significantly to the field through various research publications of national and international repute. Sir has also taken on leadership roles as the organizing secretary of HEMAT CME 2015 at JIPMA and was also the quiz master at the National Hematology Postgraduate Quiz Hematocon 2018. Welcome, sir. The stage is yours.
Thank you for that kind introduction. Hope I am audible.
Yes, sir.
I'll just share my screen.
Sir, it's visible.
Okay. So first of all, good morning to you all, and I thank the organizers of Cascade for inviting me for this lecture. And it has been a privilege to work with the Team Jubilee for last many years. And in fact, the next few minutes or the next 20 to 30 minutes, what I'll be briefing upon will be an inherited bleeding disorders. We'll touch upon the basics of diagnosis and we'll highlight the management of a few of them. As you know, inherited bleeding disorders is a huge area, so I'll be limiting my talk mainly to the most common of the inherited bleeding disorders, which is hemophilia. And I'll also touch upon a few of the rare bleeding disorders. I'll be omitting, I will not be speaking on platelet-related inherited bleeding disorders and von Willebrand, because that itself is a session for later. So the outline of my talk will be first few slides on the basics, and we'll go to hemophilia in detail, and we'll touch upon the rare bleeding disorders. So before we go to the diagnosis and the management, we should know how bleeding starts. This is something which is very common, and you all know, but I'll just to refresh on this. So whenever we have a wound or a bleeding tendency, the first thing which tries is vasoconstriction, which will help to reduce the blood flow over there, followed by a platelet plug formation, which is a temporary one, and then the initiation of the clotting cascade, which helps stabilize the fibrin clot. So the conventional way of learning a bleeding pathway or the hemostatic pathway is to divide it into intrinsic and an extrinsic pathway. Now we know that this is a cascade and which is interlinked. But for understanding purpose, it is better that we stick to it so that we know where all the pathways and what all deficiencies can happen. So to put it very simple, we have the tissue factor pathway, the extrinsic pathway, and the intrinsic pathway. And they culminate in the main step, which is the generation of thrombin with the help of an intrinsic or an extrinsic tinase or 10 activated factor 10, which along with the activated factor 5 helps in formation of thrombin. Thrombin then converts fibrinogen to fibrin, which stabilizes by the factor 39. So a deficiency of any of these pathways can in fact lead on to a bleeding tendency. So we'll come to hemophilia as such. Hemophilia is an inherited bleeding disorder where there is a lack of either factor 8, which is hemophilia A, factor 9, which is hemophilia B, or in fact factor 11 deficiency, which is confirmed as parahemophilia or hemophilia C. It originates from the Greek word hema, which means blood, and philia, to love. And almost all cases, practically, hemophilia is inherited, and it's an X-linked inheritance, as we all know. It is expressed in males and it is carried by females. The important thing is the severity level of the disease, because this disease runs in family. Severity level is consistent among the family members. But it is also important to understand that approximately 1/3 of cases of hemophilia are new mutations. So you may not definitely get a family history in some cases. So understanding factor 8, which is hemophilia A. So the mutations in this factor 8 result in hemophilia A. And there are umpteen number of mutations which are identified. And based on what sort of mutations you identify, you can have the severity of the disease can vary, starting from insertions, deletions, or single base pair changes. More often, severe cases of hemophilia A have a large inversion in the factor 8 gene. What it does is it basically decreases the amount of factor 8 synthesized, and that leads to the deficiency of factor 8. And this is a very common slide which is always shared to know the inheritance. The striped lines in the red is a carrier, which is a female, and the highlighted dark ones is a male. So this is with this pedigree chart, we need to understand two things. One is that females are usually a carrier and males are always the expressors. But there is a theory in itself where you can have a female hemophilia. That happens when your male, which is an affected male, marries a carrier female, and their female can have a female hemophilia. Another way of explaining a female hemophilia is if you have lionization or X inactivation, where the prominent expressed gene manifests itself. So, if you look at the incidence of hemophilia, we know hemophilia A or factor 8 deficiency is the most common, which is around 1 in 5,000 male newborns in all ethnic groups. And hemophilia B is much rarer, which is around 1 in 30,000 male newborns. So we look at some data from India. So this is published in around 10 years back, 2014. You have to understand that this data does not capture the actual burden of disease in India, because whatever is reported in the registries is being highlighted in this slide. The estimated patients living with hemophilia is around 75,000. The diagnosis rate is around 20%. And the patients who are diagnosed with hemophilia per year is around 17,000. Unfortunate is the subsequent points which are highlighting, that is the treatments availed by the patients with hemophilia, although we are currently seeing a better trend in this, because what was the treatment of hemophilia 50 years back in the West is many times still adopted, that is the clotting factor concentrates. In many of the Indian areas, the FFP cryo is still sometimes used as a sad state of affairs in a developing country like us. And it's again more than 85% of patients with hemophilia are crippled by the age of 15 years. This is a data 10 years back. With the advancements which we have made in the field, with the group, our Indian Hemophilia Society coming in, we have more focused activities in hemophilia, and I think this will come down in the future. So hemophilia is classified into 3: mild, moderate, and severe. It's based on the factor 8 activity. So less than 1% is severe, 1 to 5% is moderate, and more than 5% is mild. Understanding this is important because it defines the pattern of bleeding. As expected, a severe hemophilia has more number of bleeds, and a mild hemophilia may go unnoticed even into adulthood. So among the severities, compare between hemophilia A and B, 60% of hemophilia A are severe, and this percentage comes down in patients with hemophilia B. So how do you go about a diagnosis of hemophilia? Again, starting from your history, pattern of bleeding, and then comes the lab. The lab has 3 aspects. Look for a screening evaluation, mixing studies if indicated, and then go for the factor assays, and rarely you also do the mutation analysis. It is also important to understand that von Willebrand's disease, especially the severe ones, type 3N, type 2N and type 3, can mimic a clinical presentation of hemophilia with similar pattern of bleeding. Early symptoms is an unbearable pain in the muscles and joints, especially when the baby starts walk in his knees or crawls. And most of the time, this is precipitated either by a trivial trauma or not even a definite history of injury may be available. Now, the problem is once you have a joint bleed in a patient with hemophilia, this itself is a vicious cycle. So blood being an irritant to synovium, you can have a synovial hypertrophy. Hypertrophied synovium is vascular, that again bleeds, and this cascade continues. Should we also be aware of certain complications which can happen in patients with hemophilia, especially if they have a muscle bleed, which can lead on to a compartment syndrome or the pseudotumor, which can compromise the neurovascular bundles over there, and a hemarthrosis, which is having an excruciating pain and have a later effect in terms of a joint damage. The life-threatening bleeds is mainly three: intracranial, retroperitoneal, retropharyngeal. Identifying this, suspecting and treating early is very important. But the commonly affected pattern of bleeding is joint and muscular bleeds. The joint bleeds dominate. And among the joints, the knee, elbow, ankles are the most common sites where you get the bleeds. Now, how to identify a bleed? Many a time, once the child grows up, they have this aura where they are aware of when the bleed is about to happen. But beyond that, with the latest available investigations which we have, X-rays, ultrasound, and MRI. MRI, if you look at, has a maximum sensitivity because it identifies right from the face where you have an iron deposition. So this is how a joint is damaged in a patient with hemophilia. Once the bleed happens, the iron deposits, triggers of a synovitis, which becomes chronic, and the cartilage is damaged. Once the cartilage is damaged, the bone is involved, that finally leading on to a crippling arthropathy. Identifying an early bleed, identifying the early iron deposition stages, even by an ultrasound, simple ultrasound, can help you to identify any joint and then prevent it from further bleeding. Now, factor assays are the one which is commonly resolved to diagnose a patient with hemophilia. But in a resource-limited setting, this investigation, an absorb or an age serum, has importance. Because if you have a deficiency in factor 8, it shows correction with the adsorb plasma, but age serum will not correct because it is factor 8 deficient. So this algorithm is important to understand in a resource-limited setting. There are, of course, similarities and differences in patients with hemophilia. The similarities being X-linked inheritance, clinical presentation, and the bleeding sites. Prolonged hepatity is the initial clue for both this, and the principles of management and in treatment is almost the same. But of course, there are differences. Hemophilia A, factor 8 gene is much high in a molecular weight. This has importance when it comes later into therapy. And the severity, the severe hemophilias are more of hemophilia A. The risk of inhibitor development, that is also more common with hemophilia A. And the half-life of the factors is also different because hemophilia A therapy, you have to dose it twice a day, whereas hemophilia B therapy, it is once a day. The treatment starts with the basic principles, which is the acronym PRICE, where P stands for protection or pressure, R for rest, ice, compression, and elevation. This is the first thing to be done and educated for any patient with a suspected joint bleed. Then comes your anti-hemophilic factor replacement. The dosage, to put it simply, factor 8, 1 unit per kg will raise around 2%. You have to dose it twice a day because of the half-life. It was factor 9, 1 unit per kg will raise by 1%, and once a day dosing is sufficient. And how much levels to target? For a routine bleed, soft tissue, muscle bleeds, and even some joint bleeds, in the Indian scenario, around 50% correction should be fine. Whereas in a surgical situation or the life-threatening bleed situations, which I mentioned earlier, you should target an 80 to 100% correction. Equally important as medications is the role of physiotherapy, and an occupational therapist is very important in the management of hemophilia patient with the joint. Many of the time, these children need psychological counseling because they can't exert or they can't be active many a time as their peers. But with the available measures, we can give them a good quality of life. Now we coming with a hemophilia day that is in 2024, April 17, where the theme is equitable access for all, means factor availability should be equitable. There are certain preventive steps, preventive measures which all hemophilic patients should understand, which is triggering factors should be avoided, antiplatelet drugs should be avoided, NSAIDs, aspirin. Narcotics is many a time used for the hemophilic pain, but it should not be addictive. That should be monitored. You should immunize a child. You should never advise against immunization. Only thing is, deep intramuscular injections can be avoided and deep subcutaneous injections can be administered, and selecting the smallest possible needle and applying pressure or ice pack is important. Dental care is important, and in case of dental extractions or dental bleeding, you have to give antifibrinolytic agents. Now coming to the main damage which happens in the hemophilic arthropathy, where you need to give good physical therapy. Many a time with a joint bleed, they tend to be inactive, gain weight. Added weight adds on to the disease burden in the joint, so weight control is important. Safe and effective painkillers, salicylic oxide, taurus oxide can be used. Judicious use of opioids to prevent addiction, and radionuclide synovectomy in a ultimately damaged joint can be offered with a joint replacement as a permanent solution. Now this chart is busy. It just shows how much of a factor replacement has to be used. So the same dictum predominates in a life-threatening emergency situation, 80 to 100% correction, and that too for 1 to 7 days, especially in a CNS bleed or a peritoneal bleed. Whereas in a joint or a superficial muscle bleed, targeting these levels of around 50%, maybe 1 to 2 to 3 days should be sufficient. So this I already mentioned, calculating the factor dosage. Now, what are the factors which are available with us? So you have the recombinant ones, you have the highly purified varieties and the intermediate purity. So which to choose is ultimately depends on the patient's pocket, because recombinant ones are expensive. But the advantage is that it is virus free, and it is usually offered in the West for all newly diagnosed or younger hemophiliacs. But it has a somewhat lower plasma recovery of factor VIII as compared to a plasma derived concentrate. Why recombinant is important is the risk of infections. As we all know, hemophilic patients in the 80s, many patients who received these clotting factor concentrates were not purified, later developed hepatitis B and hepatitis C and HIV epidemic. The intermediate purity, which is the humate P, it is basically nowadays used for 1 milligram factor correction, because the intermediate purity has some quantity of 1 milligram factor and especially used in type 1 polyp. Now, if you look at the factor VIII consumption, the per capita consumption, India stands somewhere here, the highlighted blue one. That is, per capita consumption of the usage is much, much, much less as compared to many of the developing nations. That is a sad state of affair because of the lack of awareness or the lack of finances. Now the governments are taking proactive steps to initiate factor prophylaxis thanks to the efforts of many of the pioneers in the field of hemophilia in India. The factor IX concentrate, again, you have similar options, recombinant, highly purified. And there is also a prothrombin complex concentrate which contains factor IX that can be used in some bleeding scenarios. The advantage is it has low risk of viral transmission, but there is a risk of thrombosis. It's mostly used to reverse a warfarin effect currently. Use of desmopressin. Desmopressin triggers off the release of factor VIII 1 milligram factor from the endothelial cells, and there is a sudden jump within around a one hour period after the either an infusion or an intranasal spray which is available. It enhances the platelet addition due to the increases 1 milligram factor, so it has a hemostatic purpose, especially in the nasal bleeds or the dental bleeds. And it's basically used for a mild hemophilia prior to a dental work or a minor surgery. And it's important to give a trial dose to show that there was an inadequate response. You have to see a factor 8 rising up. And the cardiovascular complications can be a menace in older patients, especially when the repeated doses are used. Now, this is all about treatment. Now, there is a whole lot of understanding regarding treatment is not sufficient because it can lead on to an arthropathy. So it is from treatment to prevention, that is prophylaxis. So since prophylaxis prevents bleeding and joint destruction, it should be the goal of therapy as recommended by the World Federation of Hemophilia. It is cost effective in the long term because it eliminates the high cost associated with the management of a damaged joint and improves the quality of life. Aim of a replacement therapy should be first of all to prevent the joint damage. So it should be initiated at the first bleed, that is called the primary prophylaxis. And it is usually a safe treatment. There is no infections, no inhibitors development generally. And the treatment can be individualized to a particular patient because the phenotype can vary. You can measure the trough levels, the recovery of factor 8, and then decide on dosage of the patient. So this is roughly how much time the factor 8 should be kept above 1%. So that is the basic aim for prophylaxis. So that converting a severe hemophilia to mild to moderate by keeping your trough levels of factor 8 above 1%. Now there are several protocols since originated from 40 years back. They have used it at high dose thrice weekly, intermediate dose thrice weekly, but there is no optimum regime and there is no standard of care. That is when a study was done both from China and from India. I could be a part of that study where we tried to use the low dose factor 8 prophylaxis, where we try to use 10 units per kg twice a day. And there was a remarkable improvement in many of these patients in terms of preventing bleeding, preventing long-term joint damage, and giving a good quality of life. So I think this has been adopted in many centers, at least twice or thrice. Low-dose prophylaxis is administered in centers which are managing hemophilia currently. There is a significant reduction in bleeding with prophylaxis. There are 3 types of prophylaxis: primary, which means at the first episode of a joint bleed; secondary, once you have an established bleed; and intermediate dose prophylaxis. So you see, the primary prophylaxis has a 90% reduction in bleeding tendencies and the number of bleeds per year. So if you look at the advantage versus disadvantage of a prophylaxis was an ultimate treatment, prophylaxis scores over because it prevents the bleeding episodes, it reduces the severity, it improves your joint quality of life and the life expectancy, but at an added cost. But the cost ultimately neutralizes, especially when the patient is followed up in the long term. Because if you have a target joint, which goes for all these of ultra-modern therapies of synovectomy, joint replacement, physiotherapy, that can be prevented if you initiate prophylaxis early. But as we know, it has to be dosed twice or thrice weekly, and most of these are intravenous administration. Getting a good vein, adhering to the treatment as the child grows into adolescence is an important aspect. So there comes the role of novel products. So novel products should have a longer half-life. They should remain effective for a longer time. It should be easier to administer. If you have a subcutaneous preparation, that is well and good. And it should prevent the inhibitors and try to provide a definitive cure. So is there a cure? We'll come to that. So if you look at the hemophilia therapy right from the 1950s to 2020s, the 80s was the time when we identified the genes, the clones were made, but that is also the same time when we know that this epidemic of hepatitis transmission happened. Then come the recombinant era. Recombinant products are still being used. A lot of recombinant products and a lot of modifications in the recombinant products in terms of prolonged half-life. Now, there are approvals even for gene therapy in hemophilia. So the research has been in such a way that always trying to invent new things. So they try to extend the half-life either by pegylating the factor 8 or fusing with the FC component of the IgG or albumin so that you can get a more half-life lesser frequency of administration. They also looked at other pathways which are not factor-based. So one is monoclonal antibody. By inhibiting the tissue factor pathway inhibitor, you can prevent bleeds. The newer drug, that is the fitusiran, which inhibits the antithrombin and stabilizes the clot. And the bispecific antibody, that is emicizumab, which is in fact become a goal or a role changer in the field of hemophilia, especially in patients with inhibitors. A whole lot of other products which are also in the pipeline. I'm not detailing into that. So regarding the extended half-life, a lot of products have been approved both for factor 8 and factor 9 deficiency. So regarding emicizumab, so this basically is what it does is it takes up the role of an activated factor 8. So it bridges an activated factor 9 with a factor 10 so that coagulation pathway proceeds smoothly even with the presence of inhibitors. So this is a bispecific monoclonal antibody. It performs the function of activated factor 8. It bridges activated factor 9 and 10, and it is unaffected by the factor 8 inhibitors. It is approved for the routine prophylaxis, adults and children with or without inhibitors. The dosage is very convenient, once a week, 3 mg per kg, followed by a weekly, fortnightly, or even a 4-weekly dosage, administered subcutaneous. So all the remarks which I mentioned earlier has come into place in this particular product. Gene therapy, there is of course a potential possibility of cure, but the preliminary results suggest that hemophilia B may have a better one because the size of the gene is less, whereas hemophilia A can be more problematic because of the large size of the factor 8 DNA and the development of inhibitors to it. But it's heartening to understand that there are 2 products which are approved for gene therapy, both for hemophilia A and B in 2023. Regarding inhibitors is always a menace in the treatment of hemophilia. It is more common in hemophilia A, and severity, the more severe the disease, the risk of developing inhibitors is also much more common. And again, genetics has some role to play, with 30% of patients with intron 22 inversion having developing inhibitors. Now, inhibitor is something, it is a high affinity IgG antibody which works against the factor 8 which is infused. So whatever you infuse does not work. There are 2 types, type 1 inhibitors and type 2 inhibitors. So type 1 inhibitors completely inactivate factor 8, and type 2 inhibitors, they follow complex kinetics. They incompletely inactivate, so they are more common as an acquired inhibitors, type 2 inhibitors. So what it does is basically, if you look at this chart, assuming that you infuse 100 international units of factor, and the inhibitors are calculated in something called as Bethesda units. So if you have 0 Bethesda units, the 100 units remain. Whereas you have 1 Bethesda unit of an inhibitor, only 50% of what is infused remains. And if you have 2 Bethesda units, only 1/4 if infused remains. So hardly any effect of factor 8. So where does this happen? The overall prevalence is around 10% in severe hemophilia, 30% in patients who are previously unexposed. The PUB stands for previously unexposed. And there are 2 types of inhibitors, high titer and low titer inhibitors. And in an unexposed patient, most of them are initially high titer inhibitors. And when do they develop? They usually develop within the very short period of exposure. So the median exposure days is around 9 to 12 when they start developing an inhibitor. So when do you suspect it clinically? Whenever the factor you use is not responding adequately, and when patient developing a breakthrough bleed during a prophylaxis, and especially you have to screen for inhibitors before the patient is taken up for any major surgery. So the frequency of monitoring, I will not go through that. So there are a lot of risk factors for developing inhibitors. The red ones, the highlighted red ones are certainly risk factor: severity of disease, family history, black race or race and ethnicity, and the type of mutation. And again, prophylaxis, if you look at, it's a green button. That means it is possibly protective in developing inhibitors. And periods of intensive treatment. So a hemophilia patient getting admitted for 7 days, getting factor. The next time you should check them for an inhibitor. So how do you treat once you have an inhibitor? There are 4 arms of it. One is you have to treat a bleed. That is an on-demand treatment. You see whether you can prophylaxis further, prevent bleeds, and you have to try to eradicate the inhibitor, which is an immune tolerance inhibition. So I look into each aspect of this. What are the options for us to treat a bleed in a patient with inhibitor? There comes the role of factor VIII inhibitor bypassing activity, which is basically a human plasma fraction with prothrombin complex factors, which includes factor 10 and factor 2. So if you look at it, how this acts, the tissue factor pathway, there is a thrombin burst, there is an inhibitor development. So what happens next is when you use FIBA, which bypasses the inhibitor and facilitates a thrombin generation. So key components of this are factor 2 and factor 10. So what they do is they drive the conversion of prothrombin to thrombin. That is where this activated factor 8 doesn't help. So ultimately leads on to generation of thrombin, which stabilizes a clot. So FIBA has its benefits and harm effects. So it helps prevent and control bleeding. It's a perioperative management strategy. It can also be used to prophylax to reduce the frequency. It is not used in factor deficiencies in the absence of inhibitors, and it is contraindicated in patients who has a history of anaphylaxis, acute thrombosis, or DIC. Dose is around 50 to 100 units of FIBA per kg, and it depends on the severity of the disorder of hemostasis, the extent of bleeding, and where it bleeds. The other product which can be used to prevent or treat a bleed is an OVO7, recombinant factor 7. So what it does is, as the name suggests, it binds the surface of activated platelets in a tissue factor independent manner, and it again promotes the factor 10 activation, and again ultimately generation of thrombin. The dosage is varied. You have a dosage ranging from 90 to 120 mics every 3 hourly until hemostasis is attained, or there is a dosage of a 270 mics dose pre-op or post-op. And for hemophilia B, you prefer a recombinant factor 7A product because they do not contain factor. There is again a risk of thrombosis with all these agents. So regarding inhibitors, it should be tested in patients' suboptimal response. Both these drugs are equally effective, but these are costly. And immune tolerance induction, which is the process whereby you gradually reduce the titer of inhibitors. There are several methods of doing it. I think it is done in NIH Mumbai. And you can always prophylax in selected patient. Coming to the last aspect of my talk, which is rare bleeding disorders. So among them, there are a lot of rare bleeding disorders. So most are transmitted at autosomal recessive. Some case of factor 11 dysfibrinogenemia may be autosomal dominant. And the rare by mean, the incidence, if you look at, the estimated prevalence is around 1 in 1 million for most of this. And among them, the most common would be factor 7 deficiency. And we also clinically see fibrinogen deficiencies, combination of factor 5 and factor 8, and factor 13 deficiency. So highlighting a couple of these here. Again, this chart highlights the replacement therapy for these rare bleeding disorders, which is not commonly discussed many a time. We have had patients who had fibrinogenemia, who had to maintain a pregnancy with fibrinogen or cryoprecipitate replacements. So that is the treatment. In our setting, fibrinogen deficiency, you can give cryo, but nowadays we have the option to give fibrinogen concentrate because it is available in the market, although it is expensive. Similarly, factor 7 deficiency, factor 7 concentrate is not easily available. What we generally use is either plasma or the prothrombin complex concentrate or a recombinant factor 7. So I'll just highlight a couple of important ones. Factor 7 deficiency. It is the most common autosomal recessive coagulation disorder. And the most symptoms are epistaxis and menorrhagia. And of course, sometimes you get factor 7 deficiency presenting as thrombosis also. These are the therapeutic options. Practical setting FFP. If the patient has enough finances, you can opt for prothrombin complex concentrate of recombinant factor 7. And here the advantage is that recombinant factor 7 can be dosed at a very low dose. I said in the inhibitor setting, it was around 100 mics, but in this factor 7 deficiency, you can go up to 10 mics per kg. Factor 13 deficiency, it is important to identify because all the coagulation tests initially are negative. you get a normal PTA, PTT fiber loads and platelet count are all normal. Many a time in the past we used to do the 5 molar clot urea lysis test, but this has its own drawbacks because you detect it only if the factor 13 is less than 5%. So ideally you have to quantitate factor 13. And the pattern of bleeding is that it usually manifests in early life with life-threatening bleeding, like CNS bleed or umbilical cord bleed. You can prophylax because even up to 5% levels of factor 13 is sufficient to prevent a severe bleed, and it has a long half-life, almost 2 weeks. So you may need to dose it only once in 2 weeks. The factor 13 concentrate is available. That is the ideal choice. If it's not available, plasma or cryoprecipitate should be considered. The last one is factor 11 deficiency. Autosomal recessive, most frequent symptoms being post-operative bleeding. And treatment is again based on antifibrinolytics, plasma, or even a factor 11 concentrate if it is available. So I come to the last slide. I thank you for bearing with me for the last 30 minutes. I'm happy to take any questions.
Thank you, sir, for the very insightful session. The forum is now open for questions. You can either type your question in the chat box or raise your hand and unmute yourself. Sir, we don't have any questions so far. So participants, if you have any queries, please type it in the chat box. We'll answer it later. So on behalf of Cascade 2024, thank you so much, Deepak sir. Next, we'll retire for
Thank you. Thank you for this.
Please, everybody, please come back at sharp 2. We have 2 more sessions left. Thank you.